We had a closeout of our session yesterday was by Dr. Julie Kanter. She gave you a bit of a teaser of some of the great revelations and a lot of the great work she's sharing. And fortune would have it that she's also our keynote speaker for today. So, without further ado, and for those of you who weren't here yesterday, Dr. Julie Kanter is a lifespan hematologist specializing in sickle cell disease. She recently moved to Alabama to become the director of the Adult Sickle Cell Disease Program and co-director of the Comprehensive Sickle Cell Research Center. Her colleagues are far and wide, her impact goes across many borders, and she's taken the time out of her busy schedule to be with us here today. To learn more about her work and to learn more about her, you can flip to page 30 in your summit book. If you haven't accessed one, they'll be available at the front desk. And leading us in today's keynote address on creating a connected community to improve sickle cell care, I introduce Dr. Julie Kanter.
Good morning. Little bit more. Good morning. I know it's Saturday, but they didn't even start till 9:30. I mean, that's pretty awesome. Well, I'm really excited to be here this morning to talk about really creating a connected community, which is a lot of the work that I focus on. When I walked into sickle cell disease, there was a couple of things I noted. The first time I went to a community-based organization meeting many, many years ago to the SCDAA, the first thing I noted was I was the only white person in the room. And I'm not kidding. And I was shocked. It just honestly hadn't occurred to me, which tells you both a lot about what I should be thinking about and what I wasn't thinking about, but also recognizing that we all really needed to start talking to each other, because the scientists were over there and the community were over here. So I've recognized that from the very beginning of my own career and have spent a lot of time and resources and probably too much lost sleep thinking about how do we bring people together. We don't have enough money in sickle cell. We don't have enough awareness. So how do we use our limited resources, harness them towards something better? So it's taken me a while, but I think we're finally on the right pathway, and that's what I'm gonna tell you about. I consult for everybody. At least once. If I like their drug, I might talk to them again. But I think it's really important that we all engage with pharma because, number one, that's where the money is, let's be honest. And number two, that's how we get new therapies. And if we don't talk to them, we'll never get the new therapies that we need. So definitely visit your sponsors, make sure you call out to them, share your opinions. So I want to talk a little bit about why I think sickle cell fell behind in this creation of community and how I spent some time trying to figure out where to go next. We talked yesterday a lot about a new model of care, and now we're going to talk about how we link those centers into an alliance of centers, and not only to work together, but to truly engage in practice harmonization, which is a little bit more complicated because getting people to do what maybe they haven't been doing is really hard. Behavior change is hard. And then a little bit about gene therapy, and I'm going to tell you a little bit more about it later today. Maybe. All right, whoops. Okay, so we talked about this yesterday, so quick recap. The old model of care wasn't working. It was pediatric-based, it was consultative. A lot of people we found living with sickle cell disease had no idea that there were specialists. They literally didn't know how to find a sickle cell specialist or that they even existed. And we also found that even other doctors didn't know that now there were people who specialized in sickle cell disease. And the needs continue to exceed the resources, and will probably be that way for a while. There are not enough physicians, there's not enough hospitals, there's not enough advocates, there's not enough educators. More than anything, there's not enough data. And if we don't have the data to show what we need, we can't get what we need. And so a lot of what we learned is how do we put that data together? And how do we then get the investment that we need to really shift this programmatic focus on improving the whole system of care, as opposed to thinking of what do I need as an individual, or what do I need as a sickle cell center, or what does Alabama need? How do we move this into a bigger picture of what does the system of care need? So what did I do? Well, I did some homework, and I started looking at what all of these other groups had done. So we spend a lot of time, I've written an article, J.J. Strauss wrote an article. We compared resources between cystic fibrosis, between hemophilia, And we should be looking more at HIV, though we haven't. But we complain a lot. Why do they get money? Why do we not have money? So I took a different approach to say, well, where did they start and how did they get to where they are now? Because maybe that'll help us develop our own roadmap. So they do. They have a lot more money and resources. Well, how did they get that money? They have a lot more medications. Well, what did they build to get those more and better therapies? And then how did they develop this network? How did they get centers to agree to work together? Because let's face it, a lot of people don't want to work together. How do they collect data? Not how do they put data in a computer, but how do they agree to get all of these different groups to collect the same data, which has been a huge challenge. And how do they allow transparency? And what I mean is, and you'll hear more about this in a second, but cystic fibrosis is an amazing example. You can actually go through their website and their centers and figure out where their best treatment centers are and which treatment centers have the highest infection rates of Pseudomonas. Well, that's unusual that you see people put their dirty laundry out there. So how do you allow that to happen and allow it to lead you to progress and not regression? So really, I started looking at the CF Foundation. They really are an amazing group. They started in 1955. They were a group of concerned parents, mostly, and said, we got to do better than we're doing. And they started with, interestingly, I didn't know this till after we'd started our own work in this area. They said, okay, what's a CF center? What do you need to be a CF center? And so they started with that, and then they said, now we need data, because we don't even know who's living longer, how long they're living, what people in Canada are doing versus what's happening in the US. We didn't even know what people in Alabama and Georgia were doing, right? And they're right next to each other. So they created the CF Registry. And this was an agreement not only to collect data, but to share data. And then they did some things that we can't really do today. They co-invested with pharma in a way that these days might be considered a conflict of interest. But they did it in a very smart way, and it allowed them to build up an amazing investment. And now they have over 200 centers in the United States. They have worldwide connections, and they accredit these centers on a rolling basis. And their survival has gone up immensely. So we know that in sickle cell disease, our childhood survival has improved significantly, but our adult survival has not. Well, CF has blown us out of the water, and they've done this strategically over time. So how do we do this? What did they do? How did they get to where they are? Well, what about hemophilia? It's another blood disorder. A lot of us work in both areas, so why are they doing a better job in some ways at harnessing resources than we are? Well, in 1945 is when the Hemophilia Foundation was founded. Again, parents of a young child concerned about their child. They went from there to the Medical and Scientific Advisory Council, and that's where they started recommending treatments and using what we would call today practice harmonization, saying we're all going to do things the same way and then measure outcomes, because that's the only way you can move forward is figure out exactly what we heard earlier, where you've been. If we don't know what is and isn't working, how do we decide what best practices are? And then they got lucky in some ways, and the Health and Resources and Services Administration, HRSA, founded a national network, and this is really what allowed them to have a launching pad. They had 135 treatment centers, allowed them to define treatment centers, make sure that those treatment centers were doing the right things at the right time, and that also is what allowed them to get into 340B funding. Oddly, a crisis often triggers change, and that's actually what also made the Hemophilia Foundation the strongest. In 1980s, the mortality rate got really severe because of hepatitis and HIV that was contaminated factor. And so never ceasing to use a crisis to move forward, that's exactly what they did, and that's where the 340B program in some ways became something that is still integral today to how they fund their centers. And they allowed it to really stretch their resources. So they could suddenly have these multidisciplinary teams that were all covered through factor products, which were of course needed by the patients. And then the CDC helped, so you can kind of hear some similarities here, right? We have a HRSA program in the US, we have a CDC program, but they had a little bit more federal recognition and more federal funding than we have. And they created a universal data collection. So again, this was the federal government in the United States saying, we're going to collect these data. It's a mandate. Still something we don't have in sickle cell disease. And now it's a group community counts that works through American Thrombosis and Hemostasis Network, or called ATHN, that does this work. So what do we hear similar? We hear that they have centers, standards, they're working together, and they're collecting data, right? Sounds very similar. So the reason I like to think about HIV, and I'm doing a lot of work adapting some of what HIV has done in the field, is that unlike cystic fibrosis and hemophilia, people with sickle cell disease face incredible amounts of stigma. And a lot of this has to do with pain medicine. Opioids just incur stigma and incur scrutiny. Nobody ever calls me and says, why do you want to give that much Lasix? But they call me and say, why do you want to give that much Dilaudid? Right? Nobody's fighting about the Lasix. So what is it about opiates that triggers such emotion? I can't completely tell you, but we know that it's there. So let's look at another group that's faced a lot of stigma and scrutiny, and that's really where HIV comes in. And in some ways, I consider myself a child of the HIV sort of community because I remember it so well growing up in the 80s. I remember the crises. I remember the extraordinary fear. I remember people saying you couldn't sit on a bathroom in a public bathroom seat, you might get HIV. Just as stupid as you give IV Dilaudid, you're going to become an addict, right? Just as uneducated, but that same stigma was there. And so I wanted to see what they had done. And in the 80s is when this really became a huge issue, and they developed AZT, which was the first FDA-approved medication. And that's when AIDS reporting was initiated by the CDC as well. And then Congress passed the Ryan White Comprehensive AIDS Act, or the CARE Act. And this is where they were able to really move forward. I'm not going to go through all of this, but again, they had some federal legislation in the United States that said, we have to treat people. They started with saying public health. How many people are there to be treated? It's that funny data problem again. Okay, great. Now, how do we engage people in care? If there are people out there, but there's so much stigma, what do we do to get them to want to come in and not be scared of the healthcare system? And then we said, how do we pay for it? And that's what a lot of what this is about. And then they put all of this together and said, we're going to measure the quality of care. So if we're going to give you money to care for people with HIV, then you have to give us quality. Again, similar, right? We looked at data, how many people are affected, we looked at how do we provide care, and then how do we measure that care. So in 1996, we had the heart or triple therapy revolution. And from there, we learned about PrEP, so you could prevent HIV. FDA had the first at-home test, and that really took away some of that stigma. And now there are just amazing therapies where now it's really considered a chronic disease and not an end-of-life condition the minute you get diagnosed with HIV. And the improvements in care have just been dramatic to get to this point. So that's what happens when everybody works together, right? So how do we do that? How do we take all of these learnings from all these other conditions and apply that to sickle cell? We need that attention. We need that highly coordinated care. We need to work together. We need to stop saying, well, there's not enough money, so I'm going to hoard my money and hoard my data so that I get the next grant and you don't, because we'll never make progress in that way. And we said, okay, we're going to choose the centers that are willing to do that. And we also recognize not everyone was going to play with us. And that was okay too. Not everyone has to play with us, right? As long as we have enough people working together, we can move forward. And then, of course, we said, well, the United States, we have a lot of people with sickle cell, but we don't compare it to the rest of the world. So how can we do what we're going to do it better, learn how to improve our own practices, and then, as I say, take the show on the road, but apply this in other places. So unlike what I just told you about all these other conditions, we didn't have a coordinated network of centers. People could not agree, still questionably agree, on the collection of longitudinal data. We don't have enough centers, so those that are there weren't coordinating well. And yet, when you compare us to hemophilia and cystic fibrosis in the United States, God, we have so many more affected people. So we need to start with getting the data, how many people are affected, where do they need the most help, how do we get more medications to people that need them, how do we get better medications, and how do we make sure that everyone can be treated equitably and ethically. So this is my part 2, right? Time for change. I showed you all the barriers, and now I want to talk about solutions. So we want to develop a community of centers. That is really our goal, to say we're going to work together, and our focus had to start with clinical outcomes. Because in a lot of ways, for many years, research was prioritized over clinical care. And that's important too. We need new therapies, but if we're not doing the bare minimum, then the new therapies aren't going to matter that much. And in some ways, that's what I'm going to tell you at the very end, is gene therapy is awesome, but what's most awesome about gene therapy is it's going to bring people into clinic to get the bare minimum that they weren't even getting before. And so we also need to agree that some of these data, we're never going to have the cold, beautiful data that you're going to have in other conditions, because there's too much anecdote, and so we have to instead say, okay, we're just going to agree on how we practice and study its efficacy. And we have to collect data. So what did we do? And we told you a lot about this yesterday, but first we said, if we're going to have an association or an alliance of centers, well, then we have to define what a center is. Literally, we could hang our shingle right up here and say we were a sickle cell center. Nobody was asking any questions. One of the things that continues to drive me crazy is all of the centers that have self-designated to be centers of excellence. Drives me nuts. What gives you the right to hang up that shingle? So we did a project as one of my grants back in the 20-teens to look at stroke screening rates. How were we doing with TCD screening for children? We looked at 28 centers. I'm not going to tell you who did the best and the worst. I am going to tell you that centers of excellence, some of them were at the bottom of that list. So what did it mean to be a center of excellence if you didn't sort of put your money where your mouth is? And in this case, your data where your mouth was. Again, where's that transparency into what we're doing and what we say we're doing? So we found these centers. We said, okay, we're going to find the centers that want to work together. Again, we knew that not everybody was going to come play with us in the sandbox, but we were going to create a community of practice. And it's really a group of people who are passionate and concerned and want to work together. Because if you don't want to work together, you've all been on a team with someone who wants to, I played soccer, so I've always had the person on the team who just wanted to score goals and didn't want to pass the ball. We all know who those people were. So how do we get more of the people who want to pass the ball to make the best combinations? And this is really characterized by mutual engagement, joint enterprise, and truly a sort of shared repertoire of resources and practices. So it also had to be a group that would say, my protocol for individualized care plans works the best, so I'm not going to share it with you. No, we had to say, we're going to all share it, and then I'm going to try to figure out why more people in Alabama get their care protocols than people in Georgia. What are the gaps there? So that's how we formed the National Alliance of Sickle Cell Centers. We started with 5 concerned individuals, happened to be all women, not saying anything there, but just FYI, got to bring that up. Sometimes it's the women getting it done, but on the real, it was just 5 of us that finally had said, we have to do this, no one is doing it for us. And of note, we actually asked other groups to do this. We said, we all have day jobs, we don't have time for this, but nobody else wanted to spend the time investing in clinical care as opposed to investing in research. And as we said, just defining centers was the first step, but that's not enough. We have to track outcomes, we have to do quality improvement, and there has to be collaboration between these centers. And there has to be a way to integrate with the community. One thing that was important to us as we formed the alliance was not stepping on everybody else's toes while we did that. We wanted to stay in our own lane. Before the alliance, there was nowhere for center members to be as a group. So we weren't taking the place of anything else. But we didn't want to take on the CBOs, the community-based organizations. We want them to be part of the SCDAA. The SCDAA in the United States is already there, so we don't want to step on their toes. We want to make them stronger while we get stronger. So how do we develop that linkage while not stepping on toes? And it's a fine line, and we continue to work that way. So what do we do? How do we develop these guidelines, these policies? And then what do we do for comparative assessment? And then developing practice harmonization. So I joke a lot, but you've never seen a fight like 2 hematologists fighting over when you get an echocardiogram. You'd be amazed. Some people want one every year, some people don't want one at all. It's an interesting argument, but it's still my favorite argument that seems to come up every single year when we talk about practice recommendations. But we said, okay, how are we going to develop these practice recommendations when we can't even agree to an echocardiogram? Well, we didn't also need to reinvent any wheels, which is something that continuously happens in sickle cell, right? Somebody does something great over here, the grant funding ends, and whatever that great thing is goes away. So how do we harness what's already there? So that's what we did for our registry. If it had been my registry, it certainly would have been grandmom, not granddad, not my registry, adopted one that was already there called the Globin Research Network for Data and Discovery. I then tried to change the name of that registry and failed, so it stayed with Granddad. The good news is we now have cousins. Those are our collaborative partners overseas because they have separate IRBs. We actually have aunt. Our auntie registry is our sickle cell trait registry, so you can see where this is going. A colleague just published a great paper, Grandchildren of Granddad. You should look it up. It's clearly not going anywhere. And then we said again, we're going to harness resources. We are going to not just use Granddad for us, for the Alliance, but let's use it for the HRSA project. Why should they collect separate data that's spending, the same money to do two different things? Let's invest in one. So through time and more time, we convinced HRSA to allow us to use Granddad as our data collection mechanism for them as well. And now we're looking at doing that for grants. So I have an R01 now through the NIH, and we're using Granddad. We're not putting a whole new collection system together so that when the grant funding ends, the data doesn't die. Then we said we have to develop a standard of care. There are some standards, right? We know that every child between 2 and 16 with sickle cell anemia needs a stroke screen, a TCD. Okay, but how often should that child be seen in the clinic? What if they're on hydrea? What if they have SC disease? There was nowhere you could look that up and figure it out. So we had to use community of practice and say, we're going to come together and make a decision and then test that decision. So how do we take a standard of care that each of us are using separately and move it into what we would call a consensus practice recommendation? And then how do we make sure those practice recommendations don't live separately in pediatrics and adult care? And this was really important because one of the things that I learned when I was in South Carolina, I had one clinic for children and adults, which I absolutely loved. I wish everybody had a lifespan clinic. But it's not always feasible, and it isn't in Alabama. And so I said, okay, but our practices can't be that different. My best example is fever. If you have a fever of 100 and you're 15 years old, on the pediatric side, you get admitted to the hospital. And on the adult side, we're like, oh, take some Tylenol and feel better. So that's not going to work. Now we're transitioning you not just between providers, but we're transitioning practices. So how do we bring those practices together? And the first meeting of the Alliance was the first time we really had several pediatric and adult providers in one room to have these conversations. We developed a process that's based in the literature called a Delphi, or in this case, a modified Delphi process. It's a series of voting, discussion to come up with practices, so that we survey centers, we get their information, we meet, we talk, we debate, we try to avoid any tears or catfights, we come up with more recommendations, and then we put it to a final vote, and every center gets one vote. It's modified to include a hybrid group. It's modified to make sure we can include all of our centers. Most of the previous Delphi processes had a max of about 40 people, and we have over 100 centers, and everyone deserves a vote. So this is published, and you can look this up now. What were the goals? To have agreement in the best possible way with the data that we have on what we're going to do, and then to study what we did to say, did it work or do we need to make modifications or changes? 2/3 equals consensus for this process, and to pass anything, you have to have at least 2/3 of the centers vote. So we have 120 centers now, so we have to have at least 80 centers in every vote. We have 2 levels of recommendations, standards or recommendations. Makes sense, standards are what everyone should be getting. Again, TCD is the best example. Recommendation, we think it's probably safe to stop your penicillin at age 5, but we're not gonna measure you if you do or do not do that, because there's not good enough data to measure you against that. So we've done several now. You can go to the website, sicklecellcenters.org, and actually download our consensus recommendations. So we said, if you're on hydroxyurea, you need to be seen every 3 months. If you get an opioid prescription, no matter what type of sickle cell disease you have, but if you're getting opioids every month, then you need to be seen every 3 months because you have severe enough disease to warrant that. Everyone should be seen at least once a year, and that's what we want to drill into everyone's heads. You need a sickle cell specialty appointment once a year, every year, because we find a huge loss to follow-up between about age 10 and 20, and that's actually where we see our kids get in the most trouble. It's not that they didn't transition, it's they never got to transition. They'd already fallen out of pediatric care. We have neurocognitive screening. We've also done some work to define a sickle cell specialist, because we all recognize that not all the specialists are actually hematologists. And so what do you need to be a specialist? Because I've also seen some people call themselves specialists that shouldn't be. So we've defined that, and now we're working on making that into a full credentialed process. Bringing everyone together, I only have like 30 seconds left, so we're gonna go quick. We founded the Alliance in 2020. Our first in-person meeting had 45 people. The coolest part of that were 10 of them were social workers, and none of them had met, talked to, or spent time with other social workers who did what they did. It was like a revelation. They could all finally vent, right? Oh my God, this is so hard. Oh my God, no one pays us enough. Do they not realize that they can't do their jobs without us? All true, right? But they never had that opportunity. So that was one of the most amazing parts. In 2023, we moved to Las Vegas. By then, we had about 110 people, and it was about 110 degrees, and I've been told we can never go back to Vegas again. In 2024, we moved to Minnesota. Everybody complained about temperature, so we went up north. That actually went pretty well, except then they complained about other things. It's always, you can't please everyone. But then we had 259 member representatives, and 170 were in person, so we continued to grow. For 2025, we had over 600 people registered. In person was more than 75%. We actually had 350 people in person, with over 700 that ended up online. We had 95 pharmaceutical colleagues in the room, which was just amazing. And we had many CBO members, but that's the group we want to increase. This was what we called creating community. This is pictures. We had an 80s dance. My colleagues on the executive committee for the Alliance said, "What do you want to do?" I said, "We need to have a dance party." Nothing brings people together like a silly dance party. Oh my God, it was awesome. Everybody said, "We're going to do this again," right? Of course we're going to do this again. This is my executive board, along with the two people in the middle who have made life happen. That's Judson and Pat, who have really spent time with us creating the Alliance as it is. So now we need to partner, and this is a partnership down at the bottom called Bet on Blood. We're aligning with Terumo, who's the agency that supplies more than 90% of the apheresis machines, so they're an obvious partner, to say how do we get more people who need apheresis to apheresis? How do we get apheresis to them? So we're looking at that. We're also looking at how we can better partner with our blood partners. In the United States, unlike Canada, we have more than one blood partner. And I actually, barely knew that there were 5 different groups who were getting blood to give to people. So how do we partner and harness when each of those groups wants to work for themselves because it's for profit? So this is a really cool opportunity, and we've already seen some amazing things coming out of that. Gene therapy, I'm going to tell you more about later, but this is what I call our pyramid. And I'm going to end with this because so many people want me to talk about gene therapy. I don't mind talking about gene therapy. It's amazing. But I really believe that gene therapy saves sickle cell disease. And I believe that because the more we talk about gene therapy, the more we talk about sickle cell disease, the more we create awareness, education, the more people who have been referred to me for gene therapy that walk out the door with hydroxyurea because they never had a specialist explain it to them. They didn't have that opportunity. Or I've had people who walk in with significant stroke, and no one's kept them on transfusion to prevent that stroke in the future. The bare minimum wasn't being done. So if gene therapy gets us to making sure everyone gets the bare minimum, then I'm there. So while gene therapy is at the top of our pyramid, we know that most people, at least for the next 5 to 10 years, won't get gene therapy. Eventually, it will be very much broadened, but we're not there yet. So in the meantime, we get everyone to a NASAC-recognized sickle cell center in the United States. We make sure every person has access to care. We need that data to measure who's doing well, how they're doing well, who could even get gene therapy. So I have to keep that gene therapy in there because it's what our government wants to hear right now. How do we increase our workforce and training for providers, right? We can't have sickle cell centers if we don't have providers. We need those trained people. We need that data collection program by the CDC that gives us the information on how many people have sickle cell disease. And that can identify who needs care, where they need care. So normally you build a pyramid from the bottom up, but because everybody's talking about gene therapy, I'm building it from the top down. And I really believe gene therapy will save sickle cell disease in this way. It's going to bring more money, more attention, more people, and more people to care, which is most important. So today we talked about some historical barriers to sickle cell disease, talked about some of the diseases that have done a better job than we have, and figured out what they did so we could then mirror some of those activities. We also talked about the National Alliance of Sickle Cell Centers, why, how, and when we founded it, how we're working towards this practice harmonization and what that really looks like and what it means, and hopefully got you excited about how we keep the momentum going and bring it up to Canada. Thank you. Any questions? I know it's early, come
Yes.
on.
Oh,
Thank you so much. I really want to congratulate you on what you've been able to achieve. There are times when we have challenges in our profession, in our career, that you can really make a change. And I think you've really, stood up to that challenge, and I congratulate you. And it's also interesting that many of the things you talk about are the same things that others have talked about, but not in the same kind of, real perspectives. And the WHO Afro, has tried to define what sickle cell treatment centers should be, who qualifies to be a sickle cell specialist, what should centers of excellence offer before they can do that. Unfortunately, I don't think they're really publicizing that, enough. And I really, applaud you again. Now, when it comes to collecting data and having registries, you've outlined it so well, why that is so important. And again, that fits into what GANSID is trying to do. And GANSID has this advantage, or that vantage point, that is global, now present in like 35 countries with like more than 80 member organizations. And having a global registry is one of the key initiatives. And I'm happy that we're going to be collaborating with the Alliance, and I hope we'll get other partners who will be interested. My final comment, now talking about learning from other chronic diseases. My late wife had chronic kidney disease. Now, when she started dialysis, she had to take a course. This was part of the counseling. Mm-hmm. And the caretaker had to be there with her. And at the end of the counseling and all that education, you had to take a test. And you have to score 100% before they say, okay, now you can go and start treatment, you're good. And that armed her so well with information that when we got to Kuwait, the nephrology service was not that well established, but she stood her ground, that this is what I know, this is what I need, this is my protocol. And I think that's something we can learn in the sickle cell disease world, to be able to empower those that live with this chronic disease. I've listened to some of the presenters yesterday, and I'm so impressed with how, eloquent, articulate, and they can, advocate for themselves. So I think we need to be a little more aggressive or forthcoming in empowering them. Let's set up some kind of curriculum for them and their caregivers, so that when they go and have encounters with the healthcare system, they're so well armed, and they know what they're talking about, and they get to educate some of the caregivers. Thank you.
Great ideas, absolutely, great ideas. And one of the things that I will comment on the global scale is when I stumbled, for lack of a better way to put it, into gene therapy. And it was because I was working at a small sickle cell center in New Orleans, and I didn't like the transplant program, and I was confident and said, I'm gonna run my own transplant program. So I was running bone marrow transplant for sickle cell specifically, and I was running the sickle cell program. There's not a lot of people that do that. And often you'll hear that sickle cell, and I'll tell you a little later about how sickle cell and transplant programs don't always get along. For me, I was the same person, it was pretty easy. So when gene therapy came to the forefront, I got to be included in that. And as a result, I remember that I went to my first European meeting in 2013 and was shocked both to hear about how people with sickle cell disease were being treated in sub-Saharan Africa, but also in England and in France, and the fact that we weren't talking to each other. So, right, it's the same disease, and yet we're not having these conversations. So I think that global unification is so important.
Agreed, and I want to thank you again for such an excellent presentation. And for me, it's more of thanking you. If anyone should lead this program that you're doing, it's you. I noticed you mentioned SCDAA, which is a patient organization. You're willing to work with the patient organization, and bringing everybody together. That collaboration is key. You have all the right ingredients to make this a success, and this is why I think it's been successful. And I want to thank you, Julie, for everything you do. Thank you.
My pleasure.
After this question, we probably have time for one more question.
Thank you very much. I have two questions, one that maybe you aren't going to be able to answer, but I was interested in the fact that you have brought in people who were not yet diagnosed with sickle cell and hadn't received any care. And in Canada, I think we sort of assume, I have to say I've assumed, that anybody with that diagnosis would have come to attention and received some kind of care, but maybe that's a poor assumption. So, and we're finding people with newborn screening now, but for new people who come to Canada, would there be a route maybe through community leaders, or I don't know what you found, or people in the community that those people trust, that could be accessed to bring them to our attention?
So it's a great question. We actually have a whole grant. You know that in sickle cell disease, you can't have a good project if it doesn't have a good name, a good acronym. This one is RECIPE, Recruitment and Engagement in Care, and somehow sickle cell gets into that acronym. And it is what we call finding the right recipe. So we're actually studying 3 different pathways to both identify those individuals, approach them, and engage them to understand what works best. We're just now heading into year 3. I think we've learned a lot. Some things that would shock you, it was easier to bring people into care in Alabama than it was in California. The opposite of what I would have thought. So we've learned quite a bit. One of the interventions that we've employed, actually we've adapted from HIV, called a linkage coordinator. I used to just call them the warm touch. And what I meant is if someone just gets a referral from the ER, we found they didn't come to the clinic 90% of the time, 95% of the time. If someone reached out, explained who we were, what we did, why we thought they should come in, they were 50% more likely to walk in the door. And what we have found is that that's got to be somebody on the level of the individuals, in the community, understands those individuals. So that's where I think you have a partnership between your hospital and your community with these linkage coordinators. So we're really hoping to bridge that as time goes on, but you would be amazed at the amount of people who don't even know they have sickle cell disease that are in the community that need care.
Okay, we're going to need a much louder round of applause. Once again, thank you, Dr. Julie Kanter.
Thank you all very much.